Today I'll be talking about intradialytic parenteral nutrition, a topic which is often debated. There are those who believe in it. There are those who don't believe in it. Basically, whenever we look at malnutrition in CKD, it basically is a veritable alphabet soup. There are terms like MIA, MICS, and in 2009, the SRNM put an end to all of this and put up the term protein energy wasting to describe a loss of body protein mass and fuel reserves in patients with ESRF. And protein energy wasting is prevalent. It's not something we necessarily only see in lower and mid-income countries. Even in countries like the US, 50 to 75% of the patients on maintenance hemodialysis have protein energy wasting. It's not uncommon at all in Singapore. Now, is protein energy wasting a consequence of chronic inflammation, or is it just poor intake? We all know that in patients with end-stage renal disease, there is elevated C-reactive protein. We also know that despite reasonably intact appetite, there's a large number of patients who can have low serum albumin or pre-albumin. So it certainly is not only a consequence of poor intake. Dialysis per se increases nutrient losses and thus increases the risk of protein energy wasting. In the past, we used to only consider peritoneal dialysis as a condition where there was significant loss of protein. But with increasing number of patients on continuous hemofiltration, hemodiafiltration, so on and so forth, we understand that nutrient losses depend on dialysis mode, the membrane use, dialysis rate, and the frequency of treatment. Whenever we see a patient in the dialysis clinic, two things come to mind. One is nutrition screening, while the other is nutritional assessment. The nutrition screening can be done by anyone. It can be the nurse who's bringing the patient into the dialysis clinic. And the usual tool they use is the malnutrition screening tool, where they just ask two questions. Have you lost weight without trying? And have you been eating poorly due to decreased appetite? If either is positive, then the patient goes for a nutritional assessment where you need qualified staff, which means a renal dietitian, who's always a part of all our dialysis clinics. Now, the nutritional assessment could be subjective or somewhere in between, or something which is a lot more objective. So we have the subjective global assessment. In the past, we used to talk about A, B, and C. Now we use a 7-point score. You have the malnutrition inflammation score, and what is more often used, the protein energy wasting score. Now, there is no single gold standard measurement for assessing nutrition. And here, the renal physician has to work very closely with our colleagues who look after renal nutrition, namely the renal dietitians. There's a whole host of things which are suggested and often not done. This is what the SRNM suggests, and this is what we do. We look at diet, we look at a history of comorbidities, we look at the protein nitrogen appearance rate, we have a look at the physical examination and the serum albumin. Now, this is what the SRNM suggests. Of these 4 criteria, at least one test in each category needs to be satisfied on 3 occasions, 2 weeks apart. So first is a nutritional intake. It could be direct assessment from food diary, and you know how notoriously inaccurate a food diary can be. It could be based on SGA score or an indirect assessment like NPNA. I would like to comment here that whenever we talk about NPNA or PCR, it's based on usually patients undergoing thrice a week dialysis. I'm not so sure how one would do it in an Indian context where the largest number of patients are on twice a week dialysis. Then we can do measurement of body mass, weight-based, or using body impedance assessment. We use the Fresenius PCM machines to do this. We can measure the muscle mass, and of course, the biochemical markers. Now, whenever we talk about the normalized protein nitrogen appearance rate, it closely approximates the protein intake. There are some fallacies of using it. It could be falsely low in the obese patients, and it could be falsely high in the malnourished patients. As you can see, once the PCR goes below 1, it seems to be associated with high cardiovascular mortality in an almost linear fashion. We all have various programs in the dialysis unit to calculate PCR, but in case we don't, this is a very simple calculation which was first published by Jindal et al. From Canada, where the NPACR is equivalent to this mathematical equation, and all we need to do is have a pre-dialysis midweek blood urea nitrogen and a post-dialysis, and from that we can work out what the NPCR is. And you know that we want an NPCR of 1.2 grams per kilo per day. That suggests the protein intake, or at least 1 gram per kilo per day. The laboratory markers of protein energy wasting include serum albumin, serum prealbumin, and serum cholesterol. Albumin by itself is a poor marker of nutritional status. And why is that the case? Its half-life is 20 days. It is negatively influenced by inflammation. It's affected by hydration, and it's negatively influenced by albuminuria. If you look at prealbumin, that's also known as transthyretin. It's a transport protein for thyroxine, a much better marker of malnutrition, something we use in our medical and surgical ICUs all the time because it's got a half-life of only 2 to 3 days. For us, less than 30 milligrams per deciliter would suggest malnutrition. It's not affected by hydration status. So any patient in the ICU, prealbumin would be better than albumin. As you can see from this graph by Scheinerberger, as the albumin drops, it is linearly associated with an increase in mortality. And so this is a very strong marker of not only cardiac mortality, but all-cause mortality in our dialysis patients. Serum cholesterol has always been associated with an increased risk of cardiac death. Interestingly, in dialysis patients, low serum cholesterol is associated with cardiovascular mortality, and this is almost a J-shaped curve. This has been shown by Kalantar Zadeh not too many years ago. So does this only hold for hemodialysis patients? Not really. If you look at the Canusa study, in peritoneal dialysis patients, there is a strong association of a low serum albumin with increased mortality. And as you can see, it's significant. Also, if you had a worse KT by V, that was also associated with an increased risk of mortality. Now, subjective global assessment, whenever we show this to our renal residents, especially in Singapore, it causes a flight or a fright response. They can never remember what the parts are, and they always have difficulty in the exit exam. Basically, A subjective global assessment, as the term is subjective and it's global. It's not very objective. And that is why in the past we had stage A, B, and C, where C was severely malnourished. Now, nutritional professionals were not very happy with this, and so we got the 7-point SGA, which is as such. And basically, every one of these criteria are rated 1 to 7, where 1 to 2 is severely malnourished and 6 to 7 is close to normal. And this is what we use in our hospital and in the National Kidney Foundation system out here in Singapore. This is done for all our patients every 6 months. Now, when we assess body composition, a lot has been said about anthropometry, using muscle mass, mid-arm circumference. And I'm sure, including Professor Saxena, she'll agree that most of us don't really do it in clinical practice. But what we do use a lot of is BIA, or the Fresenius body composition monitoring. Now, we know that if there is a mid-arm circumference reduced to more than 10% of the 50th centile, then that would suggest muscle loss. A BMI of less than 23 for the Europeans is considered to be malnutrition. For the Asians, probably 20. I basically deal with a majority Chinese population, so they're generally small, and usually the BMI in most people here would be somewhere between 20 and 25. An unintentional weight loss of more than 10% over 6 months would suggest protein energy wasting, as also a body fat percentage of less than 10%. Now, this is what the CKD5D nutritional requirements are, irrespective of whether you look at the KDOQI, the SPEN, or the EBPG. They suggest somewhere between 25 and 35 kilocalories per kilo per day. As far as the protein is concerned, the median would be about 1.2 grams. The sodium, not sodium chloride, the sodium of somewhere between 2 and 2.5 grams per day. Whenever we look at management of protein energy wasting, we must evaluate for reversible causes of malnutrition like depression, socioeconomic factors like inability to buy food, medical factors, inadequate dialysis, and metabolic acidosis. Now, when we look at nutritional support, first is having a renal dietitian advise these patients. If that fails, then we can look at oral nutritional supplements like Nepro HP, which I've given here. And if all that fails, tube feeding. And if all of this is inadequate, then we consider intradialytic parenteral nutrition, or TPN, which is what I was going to talk about today. This is what we use at our hospital. This is SMOF-Carbiven. EF is electrolyte free. It is a bag with 3 compartments, 1 compartment for the amino acids, 1 compartment for the lipids, 1 compartment for the glucose, and it has 986 mils, and it gives about 1100 calories. Now, this we only use in maintenance hemodialysis patients who are malnourished. In AKI, we don't use this. We prefer to use TPN if required. Whenever we talk about Idpn, then a few questions come to mind. One, does it improve the nutritional status of the patients as seen by changes in serum albumin, anthropometry, or the subjective global assessment? Does it improve mortality or morbidity or quality of life? Can Idpn do harm as fluid overload, chemical imbalance, so on and so forth? And what characteristic of patient should be offering this kind of therapy to? And of course, the last question is, how long do we give it for? Should we give it forever? Is it 3 months, 6 months, 1 year, so on and so forth? So this is based on an evidence-based synthesis from the Veterans Administration a couple of years ago. So this is a meta-analysis where they looked at the effect of IDPN and they compared it to oral supplements. As far as the health outcomes were concerned, there was no improvement in mortality or quality of life. However, it certainly increased or improved serum albumin. When we compared IDPN to dietary counseling, then again, there was no improvement in mortality or hospitalization, but again, it improved prealbumin. When we compared IDPN to usual care would mean assessment by a renal nutritionist, advice, and/or oral nutritional supplements. Again, while it did not affect mortality, it certainly improved 1 or 2 nutritional parameters. Now, this is important to note that the naysayers will tell you it has no role because it doesn't improve survival, while those who want to use IDPN would argue that it improves some of the nutritional parameters like serum albumin or serum prealbumin. So perhaps you needed to have used it earlier in this group of patients rather than waiting till they were very sick. There is one caveat which everyone needs to be aware of. There are no studies comparing IDPN to enteral tube feeding. The limitations of most of these studies which are available, except for that one French paper, is the sample size has always been less than 100. It's a short follow-up. It could be anywhere up to 12 weeks. Only the French study looked at 2 years. The majority of studies compared to usual care, no one's too sure what the word usual care means. So what are the indications for the use of IDPN? It would be a reasonable option in patients who fail to respond to dietary counseling and oral nutritional supplements or have malfunctioning GI tracts. This is the Changi General Hospital protocol for IDPN. And what we do here is any adult with CKD on dialysis with severe malnutrition, if they fulfill any of the following criteria: a 3-month average serum albumin less than 25, unintentional weight loss of greater than 10%, current weight at less than 90% of ideal body weight, or an SGA score of B or C, and failed attempts. The "and" is very important. Failed attempts to improve nutritional status with oral or enteral supplementation after discussion with the renal consultant and the renal dietitian. We work very closely as a team and able to meet the requirements orally. Any of these contraindications, and we would not be offering IDPN to these patients. This is our protocol for our hospital. The first IDPN session, we only give 500 ml, the second 200, and from the third onwards, we would be giving 960 ml. They need to be monitored because patients can develop hyperglycemia, they can develop hypertriglyceridemia, they can develop dysfunction in liver function tests. On an average, I use it 4 to 5 times a year in our dialysis cohort. And what is very important to remember is this is the algorithm I would hope everyone would like to use. Don't jump to IDPN. Nutritional intervention first is the GI tract functional. If it is, then the first choice is always enteral nutrition. If it is somewhat, it could be a combination of enteral and parenteral nutrition. Only if the GI tract is non-functional, we use parenteral nutrition. To conclude, protein energy wasting refers to reduced protein mass and energy reserves in a patient with ESRF. IDPN should only be considered if oral and enteral nutrition is insufficient. Thank you for your attention.